Good evening. I'd like to start first of all by thanking EONS for inviting me to present today on the digital information highway in cancer care. Boy, that's quite a mouthful. But what we're getting at here and what I'm talking about is the use of digital information to drive systems in healthcare. It's such an important topic as we are in the midst of a digital revolution. That much is clear. Data and their mining by industry play a considerable part in our everyday lives, from, say, our use of social media. You will know as much as I do that what I look at on my smartphone, say, determines what I might be shown content-wise moving forwards. We're also seeing smart meters increasing in people's homes, helping us to, say, manage our energy consumption. So we're seeing a lot of the use of digital information driving services, and vast amounts of data are collected every single minute or generated every single minute. And this applies to healthcare as much as to other walks of life. And these data in healthcare can be used to great effect. So unsurprisingly, digital technologies and digital processes are increasingly infiltrating our healthcare, and we need to be ready for it. And the question I'm posing, as you can see at the end of this slide, is, do we need a roadmap? Will a roadmap help? So my aim before Greg and Joe speak is to provide an overview of what digital health is. I'll then look specifically at the role of AI, artificial intelligence, within the health arena, and to look at how it's contributing to digital health systems in cancer care. I'll then reflect with you on factors that can influence the uptake of digital health solutions, because there are factors and it's important to recognise these and to address them, because otherwise we won't be able to capitalise on the opportunity that digital health affords. And then I'll refer to some recent research that Joe, Greg and I collaborated on to show how digital innovation can directly influence our work as cancer nurses. And then I will conclude by answering that question, yes, do we or do we not need a roadmap to help us on our way? So having mentioned the fact that digital health is becoming more commonplace, digital health solutions in healthcare, I thought I would start off by looking at some of the reasons why this might be the case. Why is it we're increasingly looking to digital health to help with healthcare services and delivery? Well, I believe, to be frank, that the drivers are many and varied. First off, I think it's driven by the incredibly high demand that we're seeing for healthcare services, and that's only increasing with time. We have more and more people needing our services, an aging population, and finite resources to deliver on them. So we're seeing an unprecedentedly high demand for healthcare services, and it has to be said, that's been magnified further by COVID, resulting in us all having, I think, all of us, I speak certainly for the UK, having a backlog as regards cancer care, diagnostics and treatment. And then I think in cancer, we're certainly seeing how we can best enhance the prevention and early diagnosis of cancer, because truly that's probably one of the best ways that we can make further inroads into saving lives. So maybe digital health can have a role there. And then there's the increasing push to provide care nearer to people's homes and help people live independently at home for as long as possible through providing support in self-managing their illness or indeed their symptoms. And then there's an incredibly exciting proposition of personalised medicine and what that might do in the sort of realms of improving patient outcomes and to increasing efficiency in our services, and so on. And it is suggested in all of these areas, digital health might be able to play a part. And digital health, and I should say, we're referring to technology and data that inform medical practice and improve health. So it's suggested that digital health could help with these and other areas of cancer care and health generally. And if that is the case, if it truly has the possibility for enhancing all these different areas of our working lives, surely then we're on to a winner. And digital health solutions come in many guises, from, say, telephone-delivered interventions through to more complex managing and monitoring in the home, through to advanced diagnostics, wearables, apps. Digital health encompasses all these. And increasingly, they are incorporating some form of artificial intelligence. So what is the role of artificial intelligence, AI, within digital health? Well, it's one area I think that is particularly exciting. AI is incredibly exciting, where computers mimic human problem solving and decision making, but on a large scale. And much investment is going into developing AI-driven systems that undertake everyday tasks like analysing X-rays, say, or mammograms, and other images or specimens. Because when done by clinicians, these tasks are time-consuming, and there's always a risk of human error due to their repetitive and tiring nature. But this doesn't happen with machines. In fact, machines thrive on repetition and they learn from it. We're also seeing artificial intelligence, notably machine learning, used to analyse pre-existing data, including trial data or repositories of routinely collected data. And these data repositories may hold the answers to many questions, like development of new drugs in the case of trial data. If only we could process these vast repositories. And AI is giving us the power, the wherewithal to do this. AI can also help with identifying patients at risk of their health declining through risk stratification, and those who perhaps need to be seen most quickly based on patterns in their symptoms or other clinical parameters. So AI can also play an important role in triage. And these are just the tip of the iceberg. We're only just beginning to see how AI can help us in healthcare. I asked a few slides ago whether we think we might be onto a winner by using digital innovation and notably AI in healthcare. And thus far, it certainly would seem so. But as ever, there is a but, and it's not a small but, because this emerging contributor to care does have some challenges. When you imagine that AI often brings together data from multiple sources, but in health, these data are, by their very nature, personal and sensitive. And so if we're relaying data between home and hospital or between care providers, which is often what this entails, there has to be an issue of data security and privacy that we address. People's data must be safe and it must be secure. So that is, I would say, a complicating issue. Further, routine clinical data often used by AI can be incomplete, or in cases of images, they may lack clarity. So a way of working around this is needed. So it can, again, not be straightforward. But I think that some of the most important considerations relate to human factors. People are naturally suspicious of decision-making that has less human input. So I think we can sometimes upset the relationship between patient and professional. Arguably, there's a new person or a new machine at the table. And further, I think as health professionals, if we are going to be using some of these more complex technologies in our care, we need to make sure that patients and professionals alike are trained in perhaps entering data and indeed understanding their output. So there's definitely a training requirement and a risk that those less digitally literate patients could be disadvantaged. So, as I say, AI is not without its challenges. And this slide really depicts that a continuum where some digital health applications mean that the patient remains quite close to the professional looking after them. So on the left-hand side of the slide there, we're talking really about digital health where there's still a closeness between the physician and the patient. So maybe if we think about telehealth, where we might be providing information and support by telephone or follow-up by telephone, there's still that human element, that human touch, and I think the patient can feel that closeness. Then there are, if you move sort of to the midpoint, there are more hybrid approaches where the human and the technology play perhaps an equal part, where you might have AI-driven diagnostics, which might be informing clinician decision-making, or you might have a clinician-supported remote self-management system, whereby a person's being monitored in their home and there may be an alert which suggests to the health professional need to get in touch with the patient. So there's a level of removal there, I guess, a level of distance that's incorporated. But what we're not really seeing as yet, and arguably you can see there's a sort of trend over time, we're not yet seeing technology dominant where the sort of technology takes over the role of the health professional, and we're certainly not at that point or anywhere near that point at the minute. But we are seeing increasingly this sort of hybrid approach where the technology alongside the clinician is a sort of what we're seeing. And I'd like to move on to, I said at the start, I'd talk through a digital health innovation that Joe, Greg and I were involved with, which you might have heard Roma Maguire talking about actually, because I think she's speaking about this at EONS as well. But it's just an example of a very successful digital health intervention, and it brings to life a little bit when we talk about digital health, what this could comprise. And this entailed the use of a mobile phone device that enabled patients having chemotherapy to transmit data daily related to their symptoms and toxicities, ones they're experiencing during their chemotherapy, in real time to their healthcare team. And the system was designed to pick up changes in well-being according to symptom pattern and severity and other things, but they're the main thing. And rather than depending on recall or patients to contact their professionals, as I say, this real-time relay of data, and it was intended to instigate early and proactive response. And it's important during chemotherapy because, as one example, it can be used in other areas as well, but patients often don't necessarily understand how unwell they should feel before they seek help. And a system that relies on patients to work that out can result in delay. So this was a system which actually was proactive. It shortened that time between symptom manifestation and response. And the response that could be resulted could either be the provision of targeted self-care advice. So this information was then relayed to them on their handheld device. They entered their data and say it determined there was something awry. The system would then say, actually, here's some advice about how you can manage your nausea better, your pain better, for example. However, when a threshold was reached, an alert was then relayed to the patient's hospital team. When it got to a sufficiently severe point, then an alert went to their hospital team. The hospital team, they then make phone contact with the patient and initiate standardized care. So as a result, toxicities and events like neutropenic sepsis were then picked up earlier than relying on patient recall. And this system of care, this particular one that we trialled, known as ASIMS, Advanced Symptom Management System, was tested in the largest pan-European trial of its kind, over 800 patients across 5 countries. And this trial found compelling evidence. The results were highly significant. It was making a clinically important difference to patients. And interestingly, yes, it was feasible to implement this quite technological solution across Europe with different healthcare systems, different IT systems, different telephone systems, and it contributed to wide patient benefit when compared to a control group having usual care. Symptoms were lower, quality of life was higher, and unmet needs for supportive care were lower. So this is just one example of how a digital health innovation can be implemented relatively easily across Europe and make a difference. And it's not showing evidence in favour of remote monitoring made possible through digital health innovation. Other research has similarly shown that this is the case. So we're going to have some quite compelling evidence of the role of digital health in remote monitoring and managing of symptoms and helping people self-manage their symptoms and issues at home and remain at home for as long as possible. So I mentioned earlier that it's not necessarily always easy to implement digital health innovation. It's very new. And I think it is easier to introduce when the innovation is co-created, when it's been designed alongside health professionals, patients, families, paid carers, commissioners, etc., so that we make sure that whatever it is that we're wanting to introduce or create is fit for purpose, that it's feasible to introduce, that it meets need, and that patients and professionals feel comfortable with it. I think that's particularly the case when there's more distance being created between professional and patient. Is it replacing a human in some way, or is it, say, like AI, in which case patients and professionals need to be certain of how it's working and that they can understand what it's delivering. I think accessibility is really important. So if we're introducing something that patients themselves might use in the home or their family members, depending on their age, actually this may or may not be easy, because often the sorts of applications, apps we might use, or if people are wearing wearables, or if they're using the mobile phone technology I referred to, there might be a level of dexterity needed, or cognitive ability, or visual acuity, which means that you could actually use whatever the device is, that it isn't prohibitively difficult based on some of these features. Also, if they are relay, say, self-management advice, we need to make sure that it's translated so that members of society who don't speak our native language can also use whatever it is that we're bringing in. And I think it's easy to overlook the aesthetic of something, how it looks, how it feels, how easy it is to use, the amount of time it might need to use something and to record your symptoms, say, or whatever the device is needing us to do. Because certainly the convenience of introducing and using a new way of doing something has to override any associated burden. Everyone has to have confidence in the system. Whatever the system is doing, it has to work safely, reliably. It has to perform well over time. It can't have glitches. If it does have, I think, understandably, the audience for which it's intended will soon switch off and say no thanks. It's important to remember as well that some people are more familiar with technology and its use. There are issues around digital literacy and age, which might mean that certain people might be disadvantaged if it's brought in wholesale and it becomes a mainstream way of supporting or delivering care. Thinking here particularly about people who are perhaps older, not only older people, but people who, for whatever reason, might be less digital literate. They just might not be familiar with or embrace digital technologies in the same way. Certainly, I think complexity can be addressed if something is quite intuitive in how we use it and doesn't need too much training, because the more training, the more complicated something is, the less easy it is to implement, and also, arguably, then the greater the risk of error and things going wrong. I mentioned data security and privacy. We have to be absolutely certain in digital health, whatever the form that's being used, that people's data are kept private and secure. And that's the same in whatever country we're in across Europe. And we also need to look to cost, because really to have much traction in our healthcare systems, then whatever we're introducing must result in cost neutrality. Certainly anything which is highly costly might be much more difficult to implement than something which is relatively cheaper or cost efficient. So we do need to keep an eye on cost to some extent. And what I'm driving at here really is to say that design matters. It really matters with anything that we're creating, but certainly with digital health. We need to make sure that what we create or bring in is fit for purpose. It is something which is valued by professionals and patients alike. It meets their needs. It's acceptable to them. It's feasible. That there are no glitches. It's reliable, etc. And what we've found with our work, both in cancer care and indeed we've done work in dementia care as well, is that it takes some very careful co-designing and trialing before we bring in anything new. And typically we've used the stepped process, which you can see on this slide here, where we might have a co-design process where we look at what the issue is, the problem that needs addressing, we look at what solutions might be available, we bring them into a lab environment where we bring professionals. When I say lab environment, it's an open environment where professionals, patients, family members can get together, try things out, see if they work. And then once we get a solution right, and we make sure that it's working in a laboratory environment, in a controlled environment, that we can simulate someone's home, but it's in a controlled environment to make sure that data streams flow okay and that things are performing as we'd hope. We then typically use it with a small number of people in a small number of people's homes, if we're talking about something which is being used in people's homes, or we try it in a clinic, and in a small scale with a group of what we call trusted users, people who can feedback, help us to improve the solution, before then trying it in a larger scale environment. And in research terms, we'll be testing it, doing larger scale testing, looking at effectiveness, looking at cost effectiveness, so cost versus benefit, and the user experience, and forever looking to improve the solution over time. And that way we go from the concept, the idea, to how actually we can deliver on the concept, but deliver it in a way which is scalable, reliable, and cost effective and meeting need. So as I say, design matters. It has to feel right, it has to look right, it has to work right, it has to be reliable, and make a good contribution to patients' lives and to those of professionals. So to conclude, we've been on a journey together today, and I think and hope you'd agree that digital health and AI do indeed offer much to our healthcare systems. But to make the digital journey successful, I think some steps, a map if you like, may help when developing or implementing a digital innovation. First, to ease the journey, whether designing or using a solution, we have to make sure it's fit for the environment it will be used in. The iterative phased co-design approach I referred to is one way that this can be achieved. If using something off the peg, it may need tailoring through similar cycles of co-design and refining before introduction. How do we avoid hazards en route on our journey? Well, we need to pilot test. Test it with small trusted group, refine as necessary, before then rolling it out. Keep an eye on the gaps created between patients and professionals. Keep an eye on those groups that may be disadvantaged through digital literacy. Then safe arrival. There are some important safety considerations with digital technologies. I've started to refer to those. You need to test and retest to check that the solution, whatever it is reliable, doesn't lose performance when patients and professionals use them, and the algorithms that drive the decisions in AI, that they're carefully validated across different groups of users. And finally, they will need to conform with national and EU codes of conduct for data-driven health and care technologies. So this is my roadmap. Yes, I do think we need a bit of a roadmap. These are some of the elements that can help ensure our journey is safe. And if you're wondering about the map on the right, it's said to be the longest bus trip in the world from Kathmandu to London, a route undertaken by a group of 40 travellers in February 1977. Fascinating fact to end on, the bus trip of a lifetime. And there I'd like to end.
Hello, everyone, and welcome to this presentation. My name is Greg Cotronilas. I'm a cancer nurse and also lecturer in nursing and healthcare at the University of Glasgow. What I'm going to try and do in the next 25 minutes or so is to present you an example research project that I'm currently involved in, which aims to bring together technology, big data, and artificial intelligence in the care of older patients with cancer. So I'm going to make a start with a bit of background to geriatric cancer care and also talk about the need to enhance follow-up care services in this particular area of practice. Then things are going to get a bit more technical, nothing to worry about though, as I'm going to explain how digital health and artificial intelligence can be used here to modernize cancer services for older people and what benefits they may bring along for patients and clinical teams. In developed countries, over half of all cancers are diagnosed in patients aged 70 years or older. This is a fact. This is something you probably already know, and this is also something you also see in your everyday clinical practice. I'm sure you also agree that older age is always factored in any decisions that have to be made in relation to treatment in cancer care. And the reason is that aging has been independently linked to complex health needs, vulnerability, and perhaps adverse outcomes, which may mean that older people might not get the treatment they need or the benefit we expect them to get from it, or even worse. For that reason, specialist oncogeriatric services are being developed, involving multidisciplinary teams and particularly specialized cancer nurses whose goal is to serve this very patient population from the point of diagnosis through treatment and perhaps also follow-up. The oncogeriatric teams want to view things a bit differently as well. With the move towards a broader view of functional versus biological age, greater attention is now placed on patient characteristics additional to aging. For example, comorbidities, social well-being, daily living deficits, nutrition, and so on. The key outcome behind determining the patient's functional age is to establish his or her functional fitness for treatment. And this requires a holistic and continuous evaluation of the patient. Its goal is to identify those patients who, regardless of biological aging, seem to be more treatment resilient and likely to benefit. As such, it is entirely possible that biologically older patients may be functionally younger and vice versa. The evaluation itself aims to maximize patient benefit and safety in the long run while reducing preventable burden and costs. Is this the case currently? You might ask. Not quite, particularly for patients at the end of treatment and about to enter the follow-up phase. Services seem to not talk to each other all the time. Monitoring may not be as intense as before, or the patients may be worried that particular important changes might go unnoticed once they leave the hospital. What's a possible solution? Let's think about modernizing oncogeriatric services. Modernization can happen in several different ways, I guess, but here I'll talk about two. One is implementation of digital health in practice. What might digital health involve here? Several things, really. For example, collection of patient-reported outcomes via digitalized prompts to understand patients' priorities, or the use of wearable devices to collect biometric data on physical activity, or the use of data that comes straight from motion sensors installed in the older patient's home to get a better picture of abilities and deficiencies at home, which also may point towards a decline in health that needs immediate intervention. By allowing for this intensive and very remote in its nature monitoring, these technologies can make the older patient more visible to the clinical team, and the clinical team becomes more aware of possible problems, and help can be offered more quickly. The second way to modernize oncogeriatric services is via use of artificial intelligence and big data. Big data is exactly what you think. Massive data sets created from monitoring multiple patients, multiple times, even daily, for long periods of time. On the other hand, artificial intelligence is, to put it simply, a way to understand what big data can tell us about all the patients as a group, but also what the data can also tell us about a specific patient with specific characteristics, so that this becomes very personalized. That's why when you hear about AI, artificial intelligence, you'll probably hear also about prediction models or prediction algorithms. So these algorithms are mathematical models that are developed and trained to make predictions. And the more data they analyze, the smarter and the more accurate they become. This can help clinical teams then, at least in theory, to anticipate issues and plan accordingly to prevent and intervene as necessary. You may ask now, what evidence do you have? My answer to you is, we are working on it. So here's the LifeChamps project. And this is a multinational project that is funded through the European Union's Horizon 2020 program and led by Aristotle University of Thessaloniki in Greece. The project involves a consortium of 15 clinical, academic, and industry partners from 10 different countries, which you can see on the right-hand side of your screen here. We have initiated the project to develop a digital support platform, which we hope can help join the fragmented piece of follow-up cancer care and support older patients with cancer. The platform will aim to integrate data about the patient coming from 4 different sources: the patient's health record, the patient-reported outcome measures, wearables, and home sensors. The idea is that pulling this data together will create a fuller picture about the patient based on a continuous flow of objective and self-reported information to both clinicians and patients themselves. And the ultimate goal will be to help support decision-making when and as it's required at the post-treatment phase. Now, I mentioned briefly patient-reported outcomes and PROMs, so you're right to think that patient self-reports will be key here. These reports will be digitalized as well. Older patients will use a smartphone application to provide monthly reports on symptom burden, medication adherence, social support, nutrition, activities of daily living, just to give you an idea of the variables that we're going to be collecting data on. The patient will have access to his or her accumulating data to self-monitor their own progress, or perhaps to monitor emerging issues that they want to speak to their clinical team about, and also access to the embedded self-care advice and information about managing cancer from within the actual smartphone application. In addition to self-reports, some passive data collection will also take place using different kinds of sensors. These include a smartwatch and also smart weighting scales for the patient to use, as well as location sensors that the researchers will install in the patient's home. The sensors will enable the flow of continuous data again into the system, which, as you have probably guessed, will create another big data set for analysis. So this rather convoluted diagram here shows how the different in-home sensors work to provide information about the patient. These location sensors work by providing the patient's exact location inside the house at different times, as well as the time spent in each room and when exactly. This can help to monitor patients' activity levels and also get insights about the patient's behavior that might point to declining physical well-being or mental well-being. For example, reduced time outside the house, or most time spent in the bedroom or in the living room, which might be early signs of physical decline or depression. Before I move on to explain the concept behind the analysis, the last bit of information about the patient will come from the electronic health record. So we're going to extract some demographic and clinical data from the patient's medical record, and these very data will actually complete our set of variables that will be ready for the analysis. So as part of the analysis, what's essential is the AI bit I mentioned before, which will be actually based on machine learning to create and help train the prediction algorithms. I have tried to borrow and adapt the second graph here on your screen to help visualize how the prediction algorithm might work in practice as more patient data become available for analysis. That's the bit on the left. On the right, you can see the care predictions, and the actual algorithm flags up a patient here as a likely case for frailty based on combining demographic, medical, biometric, and self-reported data. It is then up to the actual clinical team to interpret this data and decide what needs to be done for this patient. I know that I've mainly talked about the patient-facing end of the system, but here's now what the clinical team will actually view. We've got two components here as well. One is the Clinician desktop app. That's for the MDT to quickly view each patient separately. The data presented here include the patient's self-reports and also biometric data from the smartwatch and the weighting scale. It's one easy way to summarize data for each patient as they become available. And over time, data can also be visualized via graphs to identify any particular patterns. The second feature is the Clinician dashboard, which presents group analysis and allows the clinical team to understand the older patients as a group. One can also use filters to look for group similarities or differences by specific demographic or clinical variables. And finally, the Clinician dashboard will incorporate their prediction algorithms, which will aim to quantify the risk for a specific older patient on their clinical team's caseload to develop a specific adverse outcome. Now, as much as I hope that all this sounds exciting, I should point out that this is still work in progress. The first part of the project involved a co-creation phase with end users to understand their needs, priorities, and expectations, and to establish core patient-reported outcomes and measures, and to develop the first prototypes of the development system, and finally set the principles and rules for machine learning analysis. Our next bit of work is to roll the prototype system out to the participating sites, involve obviously all the patients and their clinical teams, and start collecting the data until the end of 2022. This will be our field testing phase to explore how feasible data collection is, what needs troubleshooting, and also how acceptable it is to both patients and the clinical teams. However, by the end of it, we're aiming to have completed the initial training and validation of 12 different prediction algorithms for frailty and quality of life for older patients with cancer. For the time being, we are holding tight on some very positive feedback we had from older patients, family members, and health professionals in the earlier co-creation phase that I mentioned before. At this phase, we involved 23 older patients with cancer and 10 family carers who visualized the developing system as the means for personalized support, easier access to information, and communication with the clinical team. This was very important given some uncertainty and concern that seemed to increase as time elapsed since the end of treatment. Moving on, our clinical group involves experienced health professionals and also managers. We were fortunate enough to involve clinicians from a wide range of disciplines and specialties, GPs, oncologists, and also cancer nurse specialists who were our top participants here. The group were very supportive of the proposed proactive functionality of the system, and many actually talked about the potential to proactively flag all the patients to the team who might require clinical assessment and intervention that current follow-up services might even miss. across all participants, expected benefits from using a system like LifeCharms were quite a few, as you can see in this shortlist here. For many, what was intriguing was the ability to monitor multiple types of information, which was seen as power to identify needs, offer quick advice, and speed up referral and access to care. Moreover, enhanced communication and collaboration was also brought up as an expected benefit to meet the pressing need at post-treatment. So if you're still pondering, is this really something for a cancer nurse? Is this really something for me? I will let Robert Nancy to very eloquently explain that thanks to technology and artificial intelligence, nursing experience, knowledge, and skills will transition to learning new ways of thinking about and processing information. The nurse will become the information integrator, health coach, and deliverer of human caring supported by AI technologies, but not replaced by them. And with this last slide, I'd like to thank you very much for your time on this talk.
It's a great pleasure to be here to talk about the challenges of implementing digital health innovations into cancer clinical practice. It's envisaged that digital health can impact the full spectrum of healthcare, starting with prevention and primary care through to diagnosis, monitoring, and treatment. This means as health professionals, none of us will escape using new technologies as they're introduced. At a policy and organisational level, much of the excitement about digital health is predicated on the belief that it will reduce healthcare costs, mitigate healthcare staff shortages, overcomes rising demand, enhances accessibility and equity, increases personalisation of care, and promotes patient empowerment. And the ambition is to move from a model of care in which hospital services are seen as better and of higher quality and where health professionals are gods, to a model where patients are in the driving seat and self-management with support from an individual social network is seen as being the optimum, and there's an emphasis on partnership with health professionals. In this model, patients are viewed as consumers who are responsible for their own health, and there's a belief that technology will empower and drive professionals to provide personalised, person-centred care. What's implicit in this model is that data is the new oil that will make it happen. Thus, it's envisaged that there will be a seamless flow of health data circulating between patients and professionals, which will enhance and improve the evidence base for healthcare practice. The key challenge in this process, as I see it, is that at the centre of the model is the relationship between the person and the health professional, and that the sharing of data and information is about connecting and communicating. So rather than digital health being a product, it instead facilitates the process of communication between patients and professionals. Thus, patients generate information about themselves and their health using digital tools, which they can then share with health professionals via a variety of media. What's central to this process is that there's someone or something to receive, analyse, and interpret that information, and most importantly, to act on it by communicating what it means back to the patient. In the rest of this talk, I'm going to concentrate on the challenges that people face in this process and how they can engage with or disrupt the process. I'm going to start with the patients. There are empowered patients out there who are using technology to improve their health. An example is people with type 1 diabetes who've created for themselves an automated closed-loop insulin delivery system using digital tools and written algorithms based on data they've generated. These systems are a DIY solution and haven't undergone full medical testing, but nevertheless, those using them report a huge improvement in their health and quality of life. However, not all patients are willing or able to use technology in this way for a variety of reasons. Just as in the current system, access to services varies by socio-economic status, so a similar situation exists when we look at how people get online, and the recent pandemic has really brought that into stark relief. So Ofcom in the UK estimates that the use of smartphones, tablets and computers to go online wanes with age, particularly in the over 65s, where you can see that there's less than 20% are using smartphones. Age UK have also recently reported that around a third of people over the age of 65 say they're offline, either because they've stopped going online or because they've never accessed it. Likewise, a similar social gradient exists for the use of computers or tablets for the least well-off. In terms of health need, we know that the burden of ill health falls most heavily on the more vulnerable members of society, and so we risk replicating these inequalities in access to healthcare if we don't address the digital divide when planning future digital health services. But it doesn't have to be like this, as demonstrated by in this randomized controlled trial by Bash et al. From 2016. In this, they asked cancer patients to report their symptoms during chemotherapy using the symptom tracking and reporting web-based system, or STAR for short, at least once per cycle. And if symptoms were severe, an email was sent to nursing staff who would then make contact with the patient. The key feature of this study was that randomization was stratified according to whether people were experienced or not at using computers. And this slide shows how those classified as computer inexperienced were more likely to be from Black and minority ethnic groups and to be less well educated. The results showed there was a significant increase in the number alive at 12 months in the STAR group, that's the yellow bar on this graph. And importantly, this was particularly the case for people who were initially classified as being inexperienced. In addition, those in the STAR group classified as computer inexperienced visited the emergency room less than their counterparts in the control group, as shown in the bottom graph. And this is important as it suggests that it is possible to mitigate the effects of the digital divide. But it required considerable time and input from the study staff, who trained the participants, ensured assessments were completed, did differential modes of completion, so patients who were judged to be computer inexperienced completed their assessments on tablets or computer kiosks whilst they were attending for treatment. And they generated symptom reports for clinicians. And so this was an expense rather than a cost saving, and this needs to be factored in when planning to implement digital health innovations into practice. There are a range of other factors that can act either as barriers or facilitators to uptake and sustained engagement with digital health tools. These relate to the usability and acceptability of the tool itself, its relevance to the person, and their motivation for using it. The influence of clinicians can both inhibit and facilitate engagement. And this quote from a study by Simblet et al. From 2018 hints at why this might be. So that what they're saying is that if communication isn't a two-way process, they're more likely to disengage. I'll now go on to consider the challenges of digital health from a professional's perspective. Historically, healthcare was set up to react to what came through the door. And if we think about chemotherapy services, we can plan when and how people receive their treatment. However, how they react to the treatment is a different matter, and we've set up procedures for responding to that. However, with the advent of digital health, we can develop a much more proactive model whereby we monitor people's health and try and anticipate and manage potential complications to try and prevent them from becoming more serious. As we move from a reactive to a proactive model of care, it can feel like two tectonic plates bumping up against each other and causing a number of problems. This clash of organisational cultures was evident in the eSmart study that I was involved in. This randomised controlled trial evaluated real-time daily monitoring and management of side effects during chemotherapy using a smartphone app. Clinicians were alerted via a Clinician handset if a patient's symptoms were judged to be moderate or severe, and they were asked to contact them to assess them and advise on how to manage those symptoms. When potential sites were approached during the setup phase, the first question that was always asked was, who will hold the handset? And it could be a deal breaker because responding to patients' alerts was seen as burdensome or that it didn't fit with their current system. And in all cases, it ended up being the nurses who held the handset. Whilst professionals may find this approach difficult to accommodate in their current workflows, anecdotally, patients found this type of proactive support reassuring and helpful. Relatively few studies have examined professionals' views about the pros and cons of digital health, and those that have highlight a number of concerns that may influence attitudes to digital health tools. For example, what impact will it have on my workload and workflow? Do I have the necessary technical skills to use it? And is it safe and effective to recommend to my patients? This is illustrated by the American Medical Association that identified that few of the apps they reviewed in 2017 have been evaluated from a clinician's perspective in terms of acceptability, usability, and integration with workflow. When acceptability and usability is poor, it can impact clinicians' attitudes, as illustrated by this quote. Likewise, the issue of clinical efficacy and effectiveness is a huge concern for clinicians who are legally responsible for their actions. For them, it's an imperative that they base their practice on rigorously generated evidence. But as this slide indicates, the evidence base for many digital tools is lacking, with only a small number of sufficient quality and quantity to warrant inclusion in clinical practice guidelines. To overcome this, digital innovators are being urged to move beyond proof of concept studies and to work with clinicians to develop robust evidence of their clinical tools' efficacy and effectiveness. Given the growing enthusiasm for using artificial intelligence and machine learning analytic methods to generate predictive risk models of different health conditions, it's important to remind ourselves of the age-old mantra, rubbish in, rubbish out, and that this applies equally to these new methods of data analysis. The data can still be biased, as these news stories illustrate. And if anything, routine data quality can be poorer than research data, as it's not subjected to the same rigorous standards of data checking. Finally, organisational factors can create challenges when implementing digital health. And I'm going to use the example of digital consultations to highlight some of these issues, as it was a technology that was used extensively during the pandemic. In this study by Wall et al. From 2020, this study by Wall et al. Was conducted prior to the pandemic. And in this, they recruited and randomized 66 cancer patients and then randomized them either to in-person or video consultations, and then assessed how satisfied they were. The graph on the right shows satisfaction was significantly higher in the video consultation group, particularly in relation to time and costs. However, it's possible that these views don't reflect the full range of people with cancer asked to participate in the study. The flowchart shows that only 20% of those approached agreed to participate. And a key reason for 18% declining participation was because they didn't have a smartphone. The use of digital consultations during the pandemic seems to provide a fuller picture of their use in real-world settings. And this is highlighted by a recent report by the UK Lung Cancer Coalition. They surveyed patients and health professionals about their views on the increased use of digital consultations in response to COVID-19. This revealed that 95% of all patients who were surveyed stated that meeting face-to-face was by far the best method of communicating diagnosis, as well as when they were having an initial consultation. And a similar finding was also reported by the oncology professionals who took part. Most virtual appointments, however, were conducted by telephone, with only 13% of lung cancer patients receiving video consultations. Almost 2/3 of professionals said lack of computer equipment to hold video consultations was a regular problem. While 75% of professionals agreed that video consultations were more convenient for patients, only 30% said they were more convenient for them. Disadvantages included being unable to share visual materials such as scans with patients, difficulties in assessing a patient's physical condition virtually, and the lack of quiet private meeting spaces in a hospital to be able to conduct video consultations. This survey exposes some of the infrastructure changes that need to happen to make video consultations workable long-term in cancer care settings. To conclude, the future of healthcare is digital, and it can offer huge opportunities to improve patient outcomes in terms of their health and well-being. I hope I've convinced you that as health professionals, we need to ensure that we don't have digital innovations imposed on us that are not fit for purpose and that may compromise the health of patients. To avoid this, we need to engage in the design, testing, and implementation of these digital health tools to ensure that it enables us to connect and communicate with our patients in a meaningful way that both empowers patients and enables person-centered care. Thank you very much.
The challenges of implementing digital health in clinical practice. And I think as we are waiting for any questions to come through, I'd like to ask both of our speakers. One question that I had about the actual buying process involved in engaging clinical teams, particularly nurses. So which do you think are the top 3 most important things that we need to consider when we try to involve clinicians in actually using digital health technology in clinical practice?
I'll go first, Greg. And I think by far the biggest issue is that whatever the digital technology is, that it has clear clinical utility for the clinician, and that so that they see the real benefit and importance of using it. And also that it's not adding significantly to their workload, that it really helps them with the work that they're trying to do. I'm trying to think of the third one. While I'm thinking about it, I'll let Emma give her response.
Thanks, Jo. I'm going to reiterate the first point of yours. Work that we did actually more in the dementia field showed, particularly actually with doctors more than nurses, but they often are sometimes the people who influence whether we can bring something in or not into healthcare. Burden was the one, real fear that it would increase workload,
and not help manage it. And my strong point is I think that it can help manage workload. If it doesn't, then whatever the innovation is, it isn't fit for purpose. So I think it must not increase burden. I think the challenge we have, Greg, actually I was going to say one more thing before we do that. Actually, I'll go back to the other one. I think what we do need to make sure is that when we are designing these things, we are co-creating them, as Joe and I think both said, to get them fit for purpose. But I think at the moment with COVID, we have our health services are so stretched, they can't find the headspace to think about how to do things differently. They're running to catch up sometimes. And even though a lot of these solutions, I think, could provide answers to the extra burden we have of managing COVID and the extra numbers of patients and how we deal with them, sometimes it's the headspace. So it has to be very clear how whatever it is that we are thinking of introducing doesn't increase burden. And for that purpose, I think it mustn't duplicate. And I think that's really important. Is it must be obvious how you can implement this so that it might take the pressure off someone else, release time for that person then to deliver some other kind of more complex care potentially that can't be managed in this manner. So it must not, I mean, I don't think machines should substitute. I don't think any of this is about substitution, but it's about complementarity and letting pressure off the system, not duplicating. And I think that's where the clever bit comes in. You need to be able to explain how introducing this means that resource can be switched to do task B. If you can show that, then you start showing efficiencies and people are keen. Things that will help: simplicity of implementation, clear instructions of how to use, and things to be glitch-free and work. That's my top tips, I suppose.
I think also the infrastructure is really important, and we've certainly seen that in the UK, whereas at times the infrastructure could do with being improved. I know in other countries that's not always an issue, but it certainly adds to the stress, I think.
I think one of the key
points. Just to say, Greg, that I can't hear you or Joe. I can't hear you or Joe, and I'm just hoping this is okay.
Can you hear me okay?
Maybe it's me.
So what I was going to say is that on top of what Emma and Joe mentioned, is that we're talking about complex interventions that are meant to deal with complex health issues. So they have to be not as complicated for health professionals, for teams to be involved, to be engaged. So I suppose this is one of the points that clinical teams need to see, that this is something that can be easily implemented, that can be to support them. And co-design, as you mentioned, Emma, and also you, Joe, is one of the key things here. And I think it's also about having a clear role about, for specific health professionals, for medics, for nurses, about how they can actually use this particular information that comes from all of these digital innovations. I don't know what you think about that. Hopefully you can hear me okay. I don't know if we have a technical problem. Is it me?
I can hear now. Might be me. I can hear you now, Greg, I think.
Right, okay. I don't know if everyone else was able to hear me.
It might just be me. I'm sorry. I can now hear you.
Okay, I can repeat my point, which was about trying to make those complex interventions that deal with complex health issues as well complicated, less complicated as possible, I suppose, and have also a clear role for the different health professionals, for the different, for medics, for nurses, in order for them to be able to see how they can use this information that comes from all these digital solutions, I suppose. So this is what I was trying to explain, and I was actually seeking your views on this point.
I think, Greg, you're quite right. There are some issues around training that we need to address. And as someone who works in a university, as we all do, and preparing health professionals, we have a role in helping people feel ready and embrace and to understand output, understand what you need to put in, understand in some cases how AI works, its value. Because actually, I think people can be quite fearful of what AI is. They can be and they don't trust it. So I think there's an educational element that we could certainly help with, which would make the introduction of digital technologies much easier and more straightforward. I think the more simple the interface is, then the easier it is for patients and professionals to use. And I think that is ideal. And anything which can help with, anything new, you would need some training, I think, probably on site, as well as the sort of training we can give in a university. Videos can do that. We don't need to do that in person. We can put things on YouTube, can't we, explaining how to introduce something new. We've got to think more cleverly and make it easier for people. It's a shame, otherwise you have this great technology, but not the wherewithal to use it, or we're making it difficult to use. I can hear, Greg, that you've got lots on your hands about to.
I know.
So, you're smiling. You've been there. Joe, do you want to add anything else from what I was just saying?
I think I totally agree about the need to upskill not just existing staff, but prepare the next generation of health professionals. And I think some of that's around troubleshooting. It's a bit like that. With computers, where the IT tech guys come along and say, have you switched it on and off again? Providing people with simple skills in order to be able to manage some of the glitches that occur. And that's certainly some of the experiences we had in eSmart. And I think probably, there's always going to be early adopters of technology, and thinking about how you can encourage and empower those people to be champions for the use of digital health and really sell it to their colleagues. I'm just thinking of a student who was a champion for introducing electronic health records in district nursing, and she really worked very hard to sell it to her colleagues, and that really made an impact on implementation into practice. So I think harnessing enthusiasm within our colleagues and all working together to try and bring everybody on board is going to be really important.
I think that's a really good point, Joe. I think you're right. Champions are important, and sharing our successes where the challenges are. This is relatively new stuff for us, so we do need to share. And the other thing I was thinking as well, this is me with my research hat on, is there's lots of talk about doing trials, etc. Clearly very important, but I think we also need some different kind of research designs where we look at how context impacts on outcomes or experience of using something, or engagement and desirability. So more of a realist approach to realist evaluations, because actually I think context, as with what we're saying, context plays a huge difference in how easy it is to implement something, where you're doing it. Do you have your champions? How do champions make a difference? Where is it easier to adopt? Why is it easier? And some of those issues when implementation, we need to be more clever from design right through to rollout. So I think it's important to just put that point forward.
Yes, absolutely. I totally agree with both of you on these points. So I'm just looking also at the Q&A box. I can't see any more questions, so I suppose that our audience are satisfied with the presentations and the points made so far. So I don't know if you have any last comments that you'd like to make. If not, I'm happy to bring this session to a close. At this point, I'd like to thank very much both of you as our excellent speakers for all of your excellent points, also the ESMO technical